recording. Thank you everybody for being here. I am really delighted to be hosting the wonderful Dana Elliott this evening. And I know a lot of you already are aware of Dana's expertise, but we have a lot to learn from her tonight. As I mentioned a few minutes ago, we are recording, of course, your video and your audio will not be in the recording, so fear not if you're worried about anonymity. The recording will just feature Dana and myself. If you have questions that you would like to submit for Dana and you want them to be anonymous, you're welcome to use the chat and just send your message to me, and I will read it out totally anonymously. We will in general have time for questions at the end of Dana's talk, and your questions don't have to be anonymous, so you don't have to send them to me, but you're certainly welcome to. And we are going to save questions to the end, so even if you send them to me during Dana's talk, we will get to them at the end of the evening. And I think it's time for me to stop talking and pass things along to Dana.
Okay, so my housekeeping on that is if I blank out or I'm not screen sharing or I've just it's just my name, something like that, please let me know, because that's not my intention. I am a physiotherapist by trade, not a computer whiz in any kind of sense. I've gotten better since COVID. We've had to, but still, your 6-year-old has probably better skills if you got a 6-year-old than I do at running Zoom. Just like normally I allow people to take questions throughout, and so I say I'll monitor the chat, but right now the chat bar keeps going away on me and I don't know why. So that's helpful that we're just going to save them until the end if that's the library's practice. So a little quick bit about myself, because I always make these presentations a little bit information heavy and long. So I'm going to try to keep it short and clear. But so I don't want to take up too much time talking about myself, but I am a women's health physiotherapist as well as a standard orthopedic sports physio. I have worked in the Sea to Sky corridor in Whistler for 10 years. Before that, I grew up in Squamish, and I've worked a whole host of areas of ski school, adaptive sports, with Easter Seals camps, as a custom ski boot fitter for a long time, as an athlete, before going back into my master's of physical therapy. And I always knew I wanted to come back to this area and work in this field of sports and injury and things that I saw physiotherapists for. It wasn't till I was working as a physio here that I really saw how women's health could be put into a normal practice of physio. When I was at school, I was always thinking of the model where the women's health physios are working out of hospitals or a very specific population. I didn't really see how it worked for the whole population. That was very naive of me, but I now really see the longer I was in the practice, the more that I needed to be working on this specific population. Now, I do tend to say women's health, and I'm still learning some linguistics and some terminology for myself. I am trained to work with male anatomy, so cisgendered males, but I also have training to work with the trans and non-binary population as well. Although my practice does tend more towards female genitalia and female organs and female hormone treatments. That's where I have taken more education. And so that's where my practice leads me to. So in this time, I've now been working as a women's health physio pretty confidently for about 8 years. That said, it makes up specifically people coming in for women's health conditions, about 50% of my practice. The other 50% of the time, it's your standard old ACL, rotator cuff, wrist tendinopathy, plantar fasciitis type stuff that we see in a physio clinic. The reason that I saw women's health physio needs, where we need to look more in depth, is we are on this major hormonal roller coaster throughout our entire life. From that men, once they finish puberty, are pretty well like this, and then some of those hormones taper off like that, but they're not going up or down like crazy things like we get. So there are different things that happen to us throughout our menstrual cycle as far as our health and wellness and our injury risk. And there's things that happen to us perimenopausally and then postmenopausally as well that do change how we can be active and in a physical state. I say physical health because under my scope of practice as a physiotherapist, there are some areas that I can't treat or work in that I would refer you on to someone. And so part of today's presentation will be on certain symptoms, certain conditions, and certain treatments, who you'd want to see for those, because that's where their specialty is, particularly anything around supplementation, medications, and diet are very specifically going into other fields other than physio. It is very important for me to have that and understand that knowledge of those things, so that when I see patients and I'm seeing things pop up with them that are striking me as very hormonally related and not physically related, that I am aware of that and sending those patients to the right person so that they know who they should be seeing to treat that symptom. So on that note, I'm going to get started on a little bit of a understanding of menopause. All of us essentially know kind of generally menopause, but a bit more of the details of it and why those are going to be important for what I'm talking about. So I'm going to try not to be too anatomy heavy, although I do love it. I also love research, so I might spew out a bunch of stats also. So when we look at menopause, there are essentially two stages of being perimenopause. So early stage, this varies in a huge wide length of time. There's no time limit on how long early menopause can last for. It is determined by the fact that your cycle has now gotten 7 or more days longer than a standard 28-day cycle. So once you're 7 or more days over, you've gone into what's called early menopause. And that symptoms may occur during here. They may not. Once again, massive variation. Late menopause usually lasts for 1 to 3 years, and it is determined when your cycle length is 60 or more days apart. And you're likely to have symptoms of menopause. Menopause itself is not diagnosed of you being menopausal or you've finished the menopause stage and now you're postmenopausal, is when you've had 2 periods, when you've hadn't had a period. So your last period happened at least 12 months ago. So until that time, you could still be considered perimenopausally. You still might get a period. Until you've gone for an entire year without having a period, you're not considered to be finished with menopause and postmenopausal. We have a good idea that this is going to happen when you have 2 periods missed. You have a 95% chance that your last menstrual cycle is going to happen in the next 4 years. So that's, really good research that tells us that. That's still a 4-year window that you're now possibly going to be having on and off periods for. When is menopause going to happen? And there are some major things that can contribute to when you're going to have menopause. So genetics is the biggest factor of when you're going to have menopause. And a lot of people say, well, when did your mom go through menopause? Or when did your grandmother go through menopause? The biggest predictor of when you go through menopause is when your sister went through menopause. So hopefully all of you have older sisters that go through menopause before you, if you haven't already gone through menopause yourself. Smoking also decreases your age of menopause by 2 years. Your general overall health. So we know that people with autoimmune deficiencies and disease disorders, particularly AIDS and HIV, being underweight, are all earlier causes of menopause, as well as general poor health. So people that have other co-founding illnesses are more likely to go through earlier menopause. Delivering more children in your life increases your age of menopause. And this is often thought that, well, you had 1 child, so you might have another child. So your anatomy's just decided that it's going to give you menopause later because there's a possibility you'll have children. Social determinants are a huge factor as well. So not actually finishing college, not even finishing high school, but not finishing college is a factor for earlier menopause, as is unemployment, a lower socioeconomic status during childhood, and all increase your chances of having an earlier menopause. Some others that people do know about that are common are surgeries. So hysterectomy, even if the ovaries are left, having a hysterectomy, you're more likely to have earlier menopausal symptoms. So the hot flashes, that stuff. Now you're not going to be having your period anymore, but that doesn't mean you've actually gone through menopause if your ovaries are still in place. Other surgeries for like ovarian cyst removal, embolization, endometriosis surgeries, those all increase your risk of having earlier menopause, as well as other information with that surgery is removal of your ovaries before the age of 65 actually increases your risk of mortality. So a shorter lifespan. So that's one major reason that they still leave the ovaries in place. A lot of people think it's just for the certain cancer or cardiovascular disease benefits, but it's also because you have a shorter lifespan if you're having your ovaries moved before the age of 65. So then when we look at what is actually happening in menopause, it's not just losing your period. We're losing your period because of changes in hormones. And we have a few major hormones. Estradiol is the main estrogen. And so that's the one that gets talked about the most, because that's the one that has the biggest shift and the biggest change during menopause and plays the biggest factor. It is produced with the developing follicle. So, sorry, I've made this really tiny print. Sorry, it's produced with the developing follicle and enters your bloodstream. So now if we're not producing any more follicles, we're not producing that estradiol. However, we do get estradiol from other tissues, like the ovaries themselves produce it, not just the follicle, and the uterus produces it, as does the liver, muscle, the brain, the bone. So there are other tissues in our body that are producing estrogens, that do continue producing estrogens as we age. This does have impact on people if you're having those organs removed for other issues. So with liver disease, liver not functioning well, people are more likely to go into earlier menopause as well, or having hysterectomy, having your uterus removed, more likely to go through symptoms because you no longer have that estrogen produced from the uterus itself. So it's not all just about the eggs and the ovaries and estrogen. Estrone also produced by the eggs, and this is converted into tissues into estradiol. And so we can still be producing estrone from other tissues and convert it into estradiol afterwards, because it is produced from different tissues. Testosterone is important for muscular function, and testosterone is also mainly produced in the adrenal glands. So people are having other adrenal conditions might be having issues with testosterone that are giving them some menopausal symptoms. Progesterone is another one that's produced in the corpus luteum of the that is going to be produced even after menopause, just at a different percentage wise. So when we're looking at these different hormones and a few others that also exist that are then can be converted into estrogens, we do know that there is value to keeping as much of our reproductive tissue as you possibly can, because those other reproductive tissues are continuing to produce estrogen throughout our lifespan, even though we've lost part of the function of those ovaries, not the full function of them, but part of the function of those ovaries. So that is one of the main reasons for maybe choosing not to have a hysterectomy, or to have only a partial hysterectomy if needed for certain treatments. Looking at hormones also, there's a lot of information about having hormone tested, like, I should go see my doctor and get my hormones tested to determine if I'm in menopause. This is actually not a recommended action, because of the fact that everyone's variability is so big. And we talked about that 4-year possible cycle of when things might happen after you lost your periods twice. Day to day, your hormones are fluctuating differently. So there's actually no good testing ability when you're in perimenopausal state to determine if you are perimenopausal or when menopause itself is going to happen. Now, getting hormones tested can be really helpful for other things though. So other things like polycystic ovarian syndrome, which causes a lot of cramping, heavier periods, other discomforts that often get claimed to be or diagnosed as perimenopausal symptoms. Hormone testing can be really good for diagnosing that. Same with thyroid testing, that it can also determine if you're having thyroid issues that are mimicking menopausal symptoms. So getting those 2 tests done to determine if something else is going on could be helpful. But once again, they're not going to tell you when you're going to finish menopause, or how far into menopause you are, or how much longer you've got. One other time we'd want to use them is for primary ovarian insufficiency. And that is where your periods have stopped before the age of 40. You have a much higher risk of mortality from heart disease. So dying from heart disease if your periods stop before the age of 40. And so therefore, if that is happening, and a higher risk of stroke and osteoporosis, as well as declining to cognitive function. So more dementias, as well as more likely to suffer from anxiety and depression. So definitely if your periods have stopped before the age of 40, you do want to be seeing your family doctor and getting your hormones testing done to determine if you need to be doing a course of treatment to help with any of that. Next, what I want to talk about are some other things called cytokines. So pro-inflammatory cytokines also change throughout our menopausal history. And cytokines are the stress markers in our system. So when they are higher, we are increasing systemic inflammation in the body. This isn't like your knee is going to swell up, but there's swelling in the gut lining, there's swelling elsewhere. There could be swelling in the brain, there's swelling in the blood cells that could be causing issues. And there's shown to be a significant increase throughout menopause and post-menopause. This is thought to be due to changes in estrogen regulation of their neurological system and also due to increased stress. It is highly correlated that people with higher levels of pro-inflammatory cytokines are more likely to have chronic pain and heart disease, as well as dementias and quite a host of other things. There is more and more information linking it to issues with digestion, allergies, food sensitivities, celiac diseases, Parkinson's disease. The research is not amazing for those. It's getting to be amazing for some, but it's still linking it. It's not, we can't say causative yet for that. But this is something that we're an area that the research is going into. And so we know that when we're going through menopause and postmenopause, we have higher levels of cytokines. It is something to be aware of, doing things that will reduce and decrease those levels of cytokines. So there is also some other research that shows that cytokines are going to increase with high intensity activity, high intensity exercise, particularly in the menopausal population. So, and when there's less reduced stress levels, reduced recovery periods. So people are going to get this inflammatory state and higher white blood cells from doing high levels of activity versus doing moderate level of activity. So just because we loved doing high intensity sport when we were in our early 30s, it might not be our best option for sport during perimenopausal time. To help deal with symptoms or other symptoms that we're having. Once again, this is some research. The research essentially on exercise and menopause in some areas is very sporadic. It's actually been researched quite well. The research, we'll go into that a little bit more, but it doesn't hold up that exercise helps with certain things, particularly ones that people are looking for some answers on. So that's a bit of understanding of what at like a cellular level is going on with our body and how that's going to affect our physical health. So non-physical changes to our health that are really important that do affect our physical health are brain fog, depression, stress and anxiety, and sleep disruptions. So other than hot flashes, I didn't mention that one because hot flashes and night sweats don't tend to affect your ability to physically exercise as much. Are not stated in the research to be as problematic for people. They're problematic for a lot of other things in life, but not as much for physical health. So brain fog. I'm going to pull this one up here because I want the next slide up. So I'm going to pull this screen share up. Let me know if this doesn't screen share.
Standing by.
Okay. Now, where is my... I don't have the screen share button at the bottom.
Oh, it might be at the top of your screen, Dana. The green button.
Oh, here we go. No, there it is.
You got it?
Okay. I've got it. Okay. Oh. My bad, I'm not on. view. Let me do that. Oh my goodness. Once again, I'm sorry, not a
That's okay. If you go down to the bottom of your screen.
slideshow.
Oh, there you
There we
go.
go.
Yeah, you got it. Perfect. Looks good on my end.
Okay. All right. So brain fog. This one is very important for me. And people sometimes wonder why I'm asking some of these questions, but it is shown to have one of the biggest factors, if not the biggest factor in chronic pain and ongoing pain is cognitive difficulties or stress, anxiety, and depression. So 2/3 of all women report cognitive difficulties during perimenopausal time and postmenopausally. Also, sleep issues affect cognition. So the big things I want people to take away out of that is that 2/3 of women, so 66%, are going to have anxiety, stress, depression, forgetfulness, and sleep issues. It's temporary. It does go away. There's heavy research on this. All the research shows that brain fog, that forgetfulness, confusion will go away when you're in a menopausal state after perimenopausal times. So see someone to evaluate you for anxiety, stress, or depression. These are the main causes, and the research shows these are the main causes of brain fog. Talk to your family doctor also, though, to rule out any other issues that could be going on, such as dementias, thyroid issues, diabetes, or sleep apnea. All of those things can lead to brain fog as well. How brain fog is treated. So cognitive behavioral therapy is the only thing that is shown to have good quality effectiveness to improve symptoms of brain fog. So this is seeing a counselor or clinical counselor or someone else that is trained for cognitive behavioral therapy. We have great access to counseling in Whistler. You can see counselors through Whistler Community Services Center. You can see counselors through public health. You just have to refer. They'll put you onto an intake. You'll see an intake nurse. And then when they can, they'll get you in to see counseling. We have a lot of counselors in town, and a lot of companies, including the RMOW and Whistler Blackcomb, offer counseling services to their employees that is outside of their benefits. So you can see those counselors, and it won't use any benefit money that you have also. So if yourself or anyone in your family is working for some employment, it is worthwhile talking to human resources to see if there is counseling that is added on top of that. The other thing that is shown to help anxiety, stress, depression, sleep, and therefore help brain fog is the standard that everyone's heard forever: moderate level of exercise, a minimum of moderate level exercise, 150 minutes a week to help with that. So counseling and exercise are the two things that are shown to have high effectiveness on brain fog, as well as anxiety, stress, depression. So onto the depression, stress, anxiety. 19 to 36% of women will report depression during menopause. That's a pretty high number. So we add that to the fact that we've got 2/3 of people having some type of brain fog. There's a lot going on in the brain that needs to be dealt with as well. Earlier menopause is correlated to higher risk of depression. We talked about that earlier. Other risks of depression for menopause is having a higher ACE score. So that's adverse childhood experience. So that's neglect, abuse, lower income status, less access to food, and other things like that. So as people that score lower on that, more likely to have depression. Having a negative attitude towards aging and menopause. So people that were taught in their culture or through their family or through their friends, or just through their personal experience that they're having, that aging and menopause are not good things and that these are bad things, are more likely to end up with depression, stress, and anxiety. Poor quality sleep, that shows up across the board for almost everything, including recovery from injury or chronic pain. So poor quality sleep. A lower socioeconomic status, so and that's for the household, not per person. Smoking. Lower social supports. So lower social supports. So less family, less friends, less access to the community, more likely to have depression, stress, and anxiety. And then visceral fat. So visceral fat is the fat that we're getting in between our organs. So not the fat that we can pinch and squeeze on our love handles, that kind of thing, but the fat that causes more of that sticky outy belly. What's unclear of that is that if visceral fat is the cause or the effect or both. So if you have higher visceral fat, are you more likely to have depression, stress, and anxiety? Or if you have depression, stress, and anxiety, are you more likely to have higher level of visceral fat? Or are you always going to have both? So depressions, anxiety, sleep, stress, I should say stress, sorry. What can help? So seeing that clinical counselor, seeing a psychiatrist, see a psychiatrist, you see you're going to be referred through your family doctor, or seeing your family doctor talk about other ways of what can help. Cognitive behavioral therapy, again, just like with the brain fog. Decreasing alcohol consumption, good sleep hygiene, which we're going to talk about, that 150 minutes of moderate exercise per week. And then importantly, evoking a relaxation response. So we also know that people that have higher levels of stress, anxiety, and depression score higher on, have higher levels of cytokines circulating in their blood. So we're going back to those pro-inflammatory cytokines again. If relaxation evoking exercise would be Yin Yoga, Qigong or Tai Chi, meditation, and mindfulness practices. This is not going out for a long run or something that's getting the heart rate up. This is exercise that is used to drop the heart rate, drop the breathing rate, and calm down the central nervous system. Okay, sleep disturbances. So 50% of women report sleep disturbances during menopause. These sleep disturbances usually come from night sweats, difficulties falling asleep, repeated wakings, early waking or sleep apnea, or as well as nocturia. So waking to have to go pee at night. Night sweats. So this is something that I got a few pre-questions regarding. Unfortunately, there's not a lot of great information on how to deal with night sweats. There's not a lot of great research that's coming up with anything. And the thought on that is that so much of it is genetic based. There is no other major factor that they can contribute to it other than genetics. So if your family members, your mother's side or your father's side, had issues of night sweats or hot flashes, you are more likely to have them. And once again, that's more highly correlated to if your sister had those issues as well. Other causes, thyroid conditions, diabetes, sleep apnea, anxiety, certain medications, and cancer. So we've already talked about essentially some of those coming up a few times. So that's why, you know, if we're having some of these issues come up, we're not quite certain if this is menopause related, see your family doctor to ask about testing for things like thyroid and diabetes or sleep apnea. What you can do about it, what we know for sure helps. No sugar alcohol 4 to 6 hours before bed is shown to make a dramatic effect in people's night sweat. Keeping the room cool with breathable materials, so cotton-based materials on the bed and the clothing that you wear. And then the last one is cognitive behavioral therapy, coming up again, has very high quality research and evidence to show that that helps with night sweat. It is about the only treatment out, like actual active treatment out there, other than reducing alcohol and sugar, because that's not really a treatment, that's just changing something. Cognitive behavioral therapy is about the only treatment that has good quality research that comes up time and time again to help with night sweats. What we know doesn't help with night sweats, I'm just gonna stop screen sharing, maybe. Stop sharing. What the research shows, and so I did get a specific question about this, about certain types of exercise. You can Google a million different pages if you want, and you're going to find thousands of protocols for different types of exercise that are supposedly going to help you with night sweats. It has actually been researched quite well. The research just keeps coming up across the board that there is no correlation. So when we look at people that have high level of fitness, are they less likely to have night sweats? No, same rate of night sweats. People that have poor fitness, are they going to have night sweats? Same rate as someone that's fit. Someone that does high intensity exercise versus low intensity exercise versus yoga versus Pilates versus HIIT. Research does not show any difference doing those activities. It doesn't show that there's not any other benefits to those activities, but regarding hot flashes and night sweats, the research is pretty well coming up that there's no correlation whatsoever to exercise. So my recommendation with that is, if you like it and you're doing it and you find it helps, keep doing it, because it's going to help in so many different ways. Or if you saw something that you read online and it makes sense to you, try it, give it a try. Does it work for you? Because what we know is that it's genetic. So with your genetics, it might work well for you and it might help, but I can't give you any recommendations because I like quality research, and quality research says that no, it unfortunately won't help. So I really dug into that one a while ago because I started myself getting some night sweats about 2 years ago, and I haven't personally found any difference with exercise. Okay. Next one, sleep apnea. So sleep apnea levels increase after menopause. They also increase with age. So men, women, risk of sleep apnea increases with age. With women, it also increases hitting menopause, kind of peaks more than that in after menopause. And they think that this is because of the drop in progesterone, you get an increased risk of that visceral fat, again, that fat in the tissues, in the organs. And when you have that visceral fat, that deeper fat, it puts more pressure on your venous return, so your blood flow return. It puts more pressure onto your heart, so heart can't function as well. Then you've got that deeper fat around your esophagus, your trachea, your bronchioles. You've got more fat in there, putting more pressure onto your ability to breathe. So that's one reason that they think that it increases after menopause, not and doesn't follow that same kind of curve that it does with men. Also, the other risk factors are, so high blood pressure is a risk factor, and waist circumference are also a risk factor. And that waist circumference does tend to go with visceral fat. Signs and symptoms of sleep apnea. So snoring, usually you'll get partners saying that you're snoring louder, or your snoring has changed, or that you're stopping breathing, you're doing the kind of snoring. That is a very common, one of the more common signs of sleep apnea. If that is occurring, how your snoring has changed or you're stopping breathing, then you should be seeking medical attention from your GP, not like going to urgent care, to be assessed for sleep apnea. Frequent waking at night to go pee. So if you are now waking at night to go pee more consistently than you used to, you should be assessed for sleep apnea. And then daytime drowsiness. So if you're much more tired, feeling like you need to have naps or just don't have the energy, good chance that you're not getting quality sleep at night because your breathing rate's not normal. You might be having some sleep apnea. So I'm going to put up the next slide because there's lots of information and I can't read it on the little ones mostly. Here we go. Okay. That was sleep apnea. There we go. Good sleep hygiene. So sleep hygiene is really important to help with quality sleep. And one of the things that has mild to moderate evidence for the hot flashes, or people that get better quality sleep have less hot flashes at night, less night sweats. That said, is there also a cause that people have less hot flashes, night sweats, are getting better quality sleep? So that's where the research is kind of out. Good sleep hygiene, what it looks like. And so as you talked earlier, this is also for risks of pain, discomfort as well. So going to bed at the exact same time and waking up at the exact same time every day of the week is shown to improve your quality of sleep. Weekends, you don't get a sleep in, you set your clock for what you know works for you. And majority of people is 7 to 10 hours of sleep. When there's research done on how well people can do those like fake driving tests, it's actually 9 hours of sleep required for people to perform at a motor level on to be able to function driving a car on one of those motor tests. People report that they need 6 hours to be able to do it, but the research shows 9 hours to be able to function well. Next part of good sleep hygiene, the bed is for sleeping and sex only. It is not for reading. It is not for watching movies. It is not for FaceTiming or online shopping or anything like that. Bed is for sleeping and sex only. You need to separate your body's drive to sleep when it gets into the bed with the other things you do in life. A cool, dark room is best. So higher temperatures, people are less likely to fall asleep as easily. Exercising daily is shown to improve sleep quality, particularly exercising before lunch if you're not sleeping well. So get the exercise in before you have your lunch, so before midday. Don't nap. Napping is correlated with poor quality of sleep and shorter sleep at night, because if you've had a nap, you're more refreshed, so you stay up longer than is necessary. If you have to nap, make it less than 20 minutes, and it has to happen before 3 p.m. to be able to fall asleep at an appropriate time of night. Other things to help induce better quality sleeping: a hot bath 1 to 2 hours before bed. So that is shown to increase the person's drive to want to fall asleep. Everyone's least favorite information that I give them, which I already gave about the hot flashes: no alcohol, caffeine, things that were once caffeinated but now are decaffeinated. So decaffeinated coffee, decaffeinated teas, herbal teas, good, not decaffeinated teas, chocolate and hot chocolate, and things that have high amounts of sugars in them. 4 to 6 hours before bed, you need to get it out of your system to be able to fall asleep properly. And that's how long it takes. The big one a lot of people don't do: go to bed when you're sleepy or tired. When you feel tired or sleepy, go to bed. Don't keep doing other things. Next, troubles falling asleep. So trouble falling asleep is not just about the hot flashes. That's a big issue in perimenopausal and postmenopausal women. So setting up a good sleep ritual: relaxing, gentle stretching, once again, qigong, breathing exercises, and meditations, particularly guided meditations, are shown to be helpful for going to sleep. If anyone has any questions on, they would like to know some information of where they could get these exercises to do, let me know, and I can provide you some of those as well, as I do have some favorites for those things also. Now, you're having poor quality sleep, you're waking up on and off because you're having hot flashes, or because you're not comfortable, or you're getting more muscle aches because of the menopause. If you've been awake for 20 minutes and you can't fall asleep, either at the start of your night or throughout when you wake up if you wake up in the middle of the night, if you've been awake for more than 20 minutes, get out of bed and do something boring. So boring things include folding laundry or reading the phone book. That do not include reading or looking at phones or watching TV. It has to be boring. Ironing things while sitting is also included in that. Okay, so these I'm kind of going to over some of the more mental health sides that affect our physical ability. Next, I'd like to talk to physical changes with our body with menopause. So with menopause, we have muscle loss of 3 to 8% after the age of 30, and that percentage increases as we increase with age, but it also increases during menopause. Muscles are a major source of energy consumption. So our muscles burn more calories than other things. So if we have less muscle, we have less ability to burn more calories. Women that are perimenopausal and postmenopausal are at a higher risk of type 2 diabetes because of the muscle loss. Second factor, weight gain. So the average weight gain is 0.8 pounds per year, or 0.3 kilos per year after the start or the onset of menopausal symptoms. This is mainly due to the muscle loss and decreased calorie burn, which increases our insulin levels, which also then makes us more prone to that visceral fat, so that fat around the organs. Both of those things, as well as hormonal changes, put us at a much higher risk of cardiovascular disease, higher risk of osteoporosis, osteopenia. This one somehow a lot of people know about. A lot of people don't know about the other ones, but luckily this one's made the mainstream media. Other physical changes: we get stiffening of muscles, tendons, and ligaments. So cardiovascular disease. So that's your heart attacks, heart failures, strokes, hypertensions, arrhythmias. They are the number one cause of death in women. 1 in 3 women will die from cardiovascular disease, and that's throughout the lifespan, but that percentage increases as we get older. Risk increases after menopause are due to increased metabolically active fats, that visceral fat, increased systemic inflammation, so those pro-inflammatory cytokines in the body, increased cholesterol and triglycerides, and decreased estrogen that might make our blood vessels less pliable. So we're going to talk to that in a moment. Our estrogen makes things stretchier and pliable, and if they're not as pliable, and so the blood vessels don't work as well. Other female risk factors, someone that has had endometriosis, polycystic ovarian syndrome, gestational diabetes while they're pregnancy, or high blood pressure during pregnancy are at a higher risk of cardiovascular disease. What do we need to do? What is shown to help with cardiovascular disease? Once again, 150 minutes a week of moderate level activity is shown to decrease the risk. We're going to talk to that as we keep going. Okay, osteoporosis. Osteoporosis or osteopenia, so the weakening of the bones. Earlier menopause has an increase in bone loss, which just makes sense. If you're got this longer period of time that you are not creating bone mass, you have a longer period of time that you're losing it. Increased risk factors other than age and menopause is genetics. Once again, biggest factor. Fortunately, it's who created you is giving you a lot of this stuff. Smoking, a 2% additional bone loss every 10 years. Alcohol, more than 3 units per day. So a unit of alcohol is 3 to 4 ounces of wine. So a lot of pours of wine are actually 6 ounces. So a lot of normal glasses of wine are considered 2 ounces or 2 units, sorry. Nutrition, so lack of calcium and vitamin D. Anorexia, so history of anorexia in life. Other medications such as depot birth control. So that's the injection birth control, steroids, aromatase inhibitors, and regular cannabis use are all shown to increase your risk of osteoporosis and osteopenia. If anyone has any questions on why that would increase your risk, I'm happy to answer as to why after also. Decreased activity levels also shown to be at a high risk because there's less stress on your bones, and we need stress on our bones for our body to want to put down new bone fibers. What helps osteoporosis? So exercise. Great exercises are racket sports, anything where we're impacting the ground quickly and putting some stress through our bones and our joints. So pickleball has just skyrocketed in this town. So pickleball, tennis, squash, and badminton are great sports. Zumba, step aerobics. It's unfortunate step aerobics don't have the trend that they had in the 80s and 90s because they are actually one of the exercises showing the highest level of bone density improvements. And dance. Running, walking, hiking, stair climbing, all shown to increase your bone mass or maintain your bone mass. And then field and court sports. What is shown to help keep your bone mass or prevent loss has been a HIIT program. This has been actually quite well researched. So doing 3 rounds of 8 to 15 exercises of deadlifts, squats, overhead press, bent over rows, push-ups, and jumps have been shown. Now, not every person is going to be able to do every one of these exercises because of other various issues. So that's why recommending any exercise program, I recommend you do see a physiotherapist or other or kinesiologist, someone that has some training to rule out other issues as to why you might not be able to do those activities. Okay, I'm going to stop sharing for a minute so I can stop staring at the screen. Oh, now I'm just, okay. There we go. Okay. So next, because I actually had not put this into my slides originally, and I got a last minute question about it. And I just thought, why didn't I put that in there? Because it's 50% of my clientele. Sports injury. What is our risk with sports injury during menopause? Well, I'd mentioned earlier that estrogen keeps our tissues pliable. It keeps them stretchier. So this is good for ligament, it keeps them stretchier. When we lose estrogens, things get stiffer and more brittle. This is actually good for ligaments. So it's good for the ACL because women are shown to have an increased risk of ACL injury. So women are 2 to 8 times greater, 2 to 8 times greater risk of ACL rupture than men. And it's shown that women are more likely to rupture their ACLs during their pre-ovulatory to ovulatory. So essentially that week, right when your period ends until you ovulate, that's kind of the week where people are at a higher risk of tendon injury, particularly ACL injury. And it's shown that at that time, women have 1 to 5 millimeter increase in elasticity of their ACL during that window. Anytime we have 1.3 millimeter or more increase, you are 4-fold higher risk of a rupture of ACL. So someone that has even more laxity is more likely to rupture. So menopause is actually believed to be risk reducing for ACL injuries. And in a town where our sports of skiing, snowboarding, mountain biking, and jumping off stuff, generally, we see a lot of ACL injuries. This is good news. You go through menopause, you are less likely to rupture your ACL, okay? So there are good benefits of being menopausal. Bad side, though, is that muscles and tendons are not as elastic anymore. And muscles contract and relax. And so that's not as big a factor. But a muscle attaches onto a tendon, that tendon attaches onto the bone. And that tendon doesn't have a contract relax ability. It has a being stretched stage. And so if that muscle is very tight, that tendon is very tight, and that muscle is pulling on it, we are at a higher risk of tendon injury as well as muscle strain injury. So menopausal women are higher risk of Achilles tendon ruptures, which I'm just going to have to say are not something we see a ton of in West. So like I see them, but I'm not really too worried about people going out and getting a Achilles tendon rupture. It doesn't happen that often. And de Quervain's syndrome. So de Quervain's is one that I'd be more worried about. And that's the one. So if you take your hand and you put your thumb in it like this, if you go like this and that causes pain, that's a marker for de Quervain's. So that's the tendons in through here being irritated from computing, smartphoning, writing, knitting, crocheting, painting, various activities that we use this risk for. And the one reason that actually was shown to be in the research was that one researcher had actually noted that more grandmothers were complaining of de Quervain's than not grandmothers. And de Quervain's is actually a common injury with new mothers because of all this kind of lifting. But grandmothers were having a higher rate of de Quervain's than new mothers. And it's because the grandmothers now have these tighter tendons and they're going and helping out their children with childcare duties, lifting up babies like this all the time, getting them tendon injuries. So when we're looking at sports injury, we're at a less likely risk of ligament damage when we're menopausal. If you're not menopausal yet and you want to know about that, approximately the week before ovulation or around ovulation is the time you're more likely to have ligament damage. So maybe not the time to try giant jumps into really sticky snow. But we are at a higher risk of certain tendon issues. So if you're having some niggly, little sprain or repetitive injury stuff going on and you are menopausal, then see someone sooner than later because you're at a higher risk of having issues with it. Okay, my next little set here, and I knew I was going to go to an hour or a bit more. This is the one that women's health or pelvic floor physio comes into play a lot. But I went into sports physio because I was treating all the other stuff. And then all of this stuff was just bombarding me too. And I was like, I need to start treating this stuff because they just go together. So women's health physio or pelvic floor physio, everyone is thinking of our reproductive organs and our vagina. And so that's where we're going next. And I will have diagrams up for that. And we're going to talk about that next and how menopause affects our urogynecological health. Now, give me a second so I can screen share that again. Okay. Nope. Okay. Urogynecological health. 80% of women that are perimenopausal or postmenopausal have genitourinary symptoms. So symptoms related to their urinary tract or their genitalia. And these are more often not vaginal and vulvar changes, pelvic floor dysfunction, incontinence, which is leaking, issues with bowel movement, vaginal dryness, or sexual pain. So these are the topics we're going to talk about next. This is a diagram of not a postmenopausal vagina and vulva. This is essentially more a nice 20-something-year-old. They don't make diagrams of postmenopausal vulvas and vaginas. So I'm going to go over a bit of the anatomy here because not everyone knows their vaginal and vulvar anatomy. So you have your vulva, which is essentially this area here, with the perineum, which is the skin and muscle that goes between the bottom of your vagina to your anus. In that you have your labia. So you have your outer labia here, and your inner labia, the inner lips there. No one's vulva and vagina look the same. Everybody's looks completely different. There is no normal looking vulva or vagina, and it changes through our lifetime. The labia and inner labia continue to grow through our lifetime, particularly the inner labia. A lot of people's inner labia, as they get older, will start to stick out of the outer labia more than they did when they were younger. Other changes that we see is that the labia start to thin. So they start to get skinnier and thinner. They're not as plump as they were when they were younger. The clitoris, here we go. Clitoris starts to shrink as we have less clitoral tissue that is sticking out. Now, what a lot of people don't realize is that clitoris is actually a wishbone. So you have the glands of the clitoris, or what everyone calls the clitoris. And then it's essentially like a wishbone of tissue that goes back and deeper into the pelvic floor around the vaginal canal, deeper in there. And so you're still, when people talk about, sex, orgasm from penetration versus orgasm from clitoris, a lot of the times, more often not, people are still getting clitoral orgasms. It's just the deeper tissue that they're getting activity on that's causing that orgasm. So that clitoris starts to shrink, which becomes a problem, as well as you start to lose the erectile tissue around it. So it doesn't plump up as much during sexual activity as it would have when you're younger. The vagina itself, so the vaginal entrance itself, becomes less pliable, and the whole vaginal canal itself becomes less pliable. It doesn't have as much stretch and as much give to it, and the tissue is thinner. And so that's also talking about essentially the, we'll go here. Here you go. So this is a cross-section look. So this would be your vaginal opening down here. This is before menopause. This is after menopause. So there's, you got your ovaries and your uterus and your cervix, and you've got this vaginal canal. This is, this tissue here, as you can see, is thicker versus it being thinner over here. We got lots of this good blood flow that allows it to plump up, allows it to have more sensory neurons feeling great things. It produces moisture. Over here, less blood flow into that area, less moisture being produced from that blood flow coming in, less sensory activity on the nerve endings for good quality sensation. The vaginal canal itself actually shrinks. And I do have a stat on how much it shrinks. Where did I write that one down? Nope, maybe I didn't. So that shrinks in height as well. So you're now shorter distance between your vaginal opening and your cervix. Other changes is that the labial tissue starts to pale in color, becomes whiter, can sometimes have red splotchiness. That red splotchiness is a sign of skin irritation, usually that capillaries are coming and being broken at the skin. Other ones notice that the pH rises. Because the pH rises in there, you're going to have a change in and higher risk of yeast infections, as well as what type of bacteria can change, because of the bacterial growth changing from one type of healthy bacteria to a different type, not saying that's unhealthy, but different type of bacteria taking over. A lot of women notice that their vaginal smell is different during and after menopause. As well as you have a higher risk of what's called lichen sclerosis, and that's where the connective tissue becomes very immobile. It doesn't have any stretch on it with menopause. Okay, so pelvic organ prolapse is next topic. So pelvic organ prolapse is the bulging of the walls of the vagina due to loss of support from the bladder, rectum, uterus, small intestine, or the vagina itself. There are a couple main types. There's the cystocele, which is anterior prolapse. So I'm going to go here. So this is a cross section through your body. You got your pubic bone. Oh, no, there you go. Okay. You got your pubic bone. You got your tailbone. You've got your bladder, your urethra, your uterus, your cervix, some uterine ligaments here, your rectum and your anus, and then your vagina. Vagina is actually quite a big canal and one of the bigger canals in our body. if we start to have prolapse, we get prolapse where either the anterior wall, so the front wall of the bladder, starts to thin or change or lose its connective tissue structure. So the wall of the bladder, weight of the bladder pushes it and drops it down, and we get a bladder prolapse, also known as a cystocele or a anterior prolapse. You can get where the posterior wall, the back wall of vagina, gets pressure from the rectum, which you end up getting a rectocele. There, this one actually has rectocele as well. This is really common during with people that have constipation or IBS symptoms throughout the lifespan. You can also get a uterine prolapse, and that's essentially where the whole uterus, the way the uterus is dropping all of that vaginal tissue down. So what causes pelvic floor weakness? I'm going to hand talk to you guys. So what can cause pelvic floor weakness? Pregnancy is the number one cause of pelvic organ prolapse and vaginal tissue weakness. So if you have been pregnant, not if you've delivered a child. So if you've been pregnant, it is the number one cause. And that is because all that connective tissue has this massive influx of estrogen and progesterone to allow everything to stretch out to accommodate baby. And then you've taken 25 plus pounds of placenta and amniotic fluid and baby and put it on top of that tissue, and it's just forcing everything down. Labor, so vaginally birthing a child, is also a factor. Bigger risk factors for forceps, vacuum assist, episiotomy, pushing more than 2 hours are all major factors of having a pelvic organ prolapse. Constipation and IBS, I also mentioned. Chronic respiratory disease, so people are coughing a lot, particularly this is almost usually related to either work conditions or smoking. Obesity, more weight, more pressure downwards. Heavy occupational at work, so people that are lifting a lot at work. Genetics, your connective tissue comes down to genetics, unfortunately. Having had a hysterectomy, so is a higher risk because you don't have those uterine ligaments and that uterus holding anything up there, so now everything can collapse down. And then menopause. So that's why you guys are all here to talk about menopause. Signs and symptoms of pelvic organ prolapse: feeling heaviness into the vagina. So feeling like something is weighted down there. I would correlate this feeling to feeling like you have a tampon that's not high enough, that's dropping down, or that is stuck in the wrong place, or a tampon that's too dry in there. That is often, for a lot of people, what they'll say a pelvic organ prolapse feels like. Or it feels like just there's a golf ball stuck in there. Is the other one I get a lot. Urinary incontinence. So if you are leaking urine, there's high risk of pelvic organ prolapse. Overactive bladder. So you are having to pee constantly all the time. You might have pelvic organ prolapse. Constipation, bearing down forcefully to have a bowel movement, higher risk of pelvic organ prolapse. Pain with sex, low back pain, and spotting or bleeding from the vagina are also symptoms that you might have with a pelvic organ prolapse and can possibly lead you to see someone about being assessed for a pelvic organ prolapse. Now, a lot of people don't know they have a pelvic organ prolapse. I would think they don't because they've had their pap tests every year. Fortunately, when that speculum goes in there, it pushes your pelvic, your vaginal tissue upwards. You cannot see any of this dropping down with a speculum assessment. You can see the uterus dropping down, you can see where the cervix is, but it doesn't tell you if you have those walls of the vagina dropping in at all. So a lot of women are not assessed during their pap tests for pelvic organ prolapse. That's what pelvic floor physios do. How do we treat pelvic organ prolapse? Let's share screen. Oh, my children might be coming. I apologize. Okay. Pelvic floor physiotherapy is considered the gold standard for treatment of pelvic organ prolapse. So across the board in the research, pelvic floor physiotherapy should be the number one prescribed treatment for pelvic organ prolapse before any other treatment. What can be done for it is pelvic floor strengthening if loss of strength is the issue. Reducing pressure systems. So if someone's breath holding, poor posture, or they're putting more pressure onto it, you don't have enough muscular strength outside of the pelvic floor. If you have poor lifting technique, you're bearing down to have a bowel movement. Those are all things a pelvic floor physiotherapist will help you assess for and develop. And then producing overall exercise therapy, general exercise, quality exercise is shown to help with pelvic organ prolapse. A pessary would be prescribed by some physios. I don't do them, or by a gynecologist and some GPs. A pessary is essentially a device like a, oh my goodness, I'm having brain fart already. A device that you'd insert into the vagina to hold the pessary up. So it's like using a diaphragm. There's a word I was looking for, like using an old school diaphragm or using a menstrual cup kind of thing to hold the tissue up and pop it open, hold it up. Topical estrogen cream prescribed by your family doctor or your gynecologist can also be used. And then the end option is surgery. And there's different types of surgeries that can help with pelvic organ prolapse. But if you're going the surgical route, you still need to have good strength or the prolapse will happen again. Therefore, to have surgery, pelvic floor physiotherapy is recommended pre and post surgically as well. So don't start with the surgery, start with the other things. Urinary incontinence. So we talked about those risks of how we know we have a prolapse and other things that happen during menopause. Over 50% of postmenopausal women leak urine. Main types of urinary incontinence, stress urinary incontinence. So this is your cough, sneeze, laugh, you're running, you're jumping, you're squatting, you're lifting, and you pee. You have stress urinary incontinence. Urge incontinence. This is when you have a full bladder, and because your bladder is full, you start leaking. Or you go, oh, I might have to go pee. Then you start leaking. And the everyone's favorite type is, I have to go pee, I have to go, you have to go pee. You finally get to your house and you're going to open your door and you pee your pants. Or you finally get to the bathroom and you're about to sit on the toilet and you pee on the bathroom floor. That is a type of urge incontinence. Mixed incontinence, super common. You pee when you do activity, you pee when you have a full bladder. And then there's overflow incontinence. And this is when you don't really have incontinence at any other time, but you dribble after you've gone pee, or you kind of have a constant like slow dribble when, because your bladder is not fully voiding. I'm just gonna stick here. Yeah. So causes of urinary incontinence, pelvic organ prolapse, one of the biggest causes of urinary incontinence. Weak pelvic floor muscles or pelvic floor muscle issues. So your pelvic floor muscles are too weak, so they can't squeeze and control, or they're so tight that they can no longer actually contract and relax to support, to work the bladder or to support around the bladder. Menopausal changes, that tissue is no longer pliable and can't contract properly. Therefore, you're leaking because you're not getting good closure. Damage during birthing. So nerve damage in the vaginal during vaginal birth. So as baby's coming down and coming out, it decides to tear some nerves and they never grow back well, or during a C-section, those nerves get cut. So both are at a similar risk of nerve damage causing urinary incontinence. Structural damage. So structural damage is more common from vaginal birthing. So this is from the pushing stage. So that can happen. So from pushing, you get structural damage. And that can happen before going to an emergency C-section. With forceps going in and pulling, the forceps themselves overstretch a tissue or tear off a tissue. That can also happen with vacuum. As the vacuum comes in, the baby's forced so much that it tears off your connective tissue so that you're no longer getting those muscles firing. And this can happen to your bladder, your urethra, your sphincters, as well as the muscles. Vaginal birthing, so things that will only happen in vaginal birth, to the bladder, urethra, sphincter, to muscle avulsion, the muscles being torn off, the levator ani muscle being damaged from too much pressure on it, or from episiotomy or perineal tearing during that vaginal birth. Structural damage that can occur during C-section is that you get scar tissue buildup and it's adhering to your bladder, and so your bladder can't move properly. Overactive bladder. Overactive bladder rates are about the same as with incontinence, and this is where your increased voids. So normal voiding is 5 to 8 times a day, and that's for a 24-hour cycle, and 0 to 1 time at night. If you are peeing more than that, particularly at night, you have an overactive bladder that should be treated, and there's a lot of treatments that can help. It can be associated with leaking, but it might also not be associated with leaking. What are treatments for incontinence and overactive bladder? Once again, pelvic floor physiotherapy is considered the gold standard, and essentially the same things I said before for that pelvic organ prolapse are the same things we're going to look at doing. Other things, though, would be lifestyle change and lifestyle modifications. So removing bladder irritants. So things that irritate the bladder are caffeine. And that could be things like we talked about before, that were caffeinated, no longer caffeinated. Alcohols, citrus fruits, spicy foods, chamomile tea, unfortunately, is a bladder irritant. So there are a few things out there. So removing those from your diet, ensuring proper fluid intake. A lot of people aren't drinking enough fluids because they think that's going to make them pee more. When your pee is concentrated, it's irritating. When it's irritating, your bladder gets rid of it more. So you're more likely to pee more often if your urine is concentrated, and you're more likely to leak if your urine is concentrated. So making sure you have adequate fluid is really important. And then also discussing medication timing with GPs. We know the risk of cardiovascular disease is higher in postmenopausal women. So those medications, a lot of those medications, particularly for blood pressure, have issues of increasing bladder frequency. And so maybe taking them at different times of day can help you with the symptoms you're having, particularly taking them earlier in the day and not before bed. The other one, bladder retraining. So that is me getting you to tell me how many times a day you go pee and poo and exactly when it happens, and looking at determining how we can make changes in that to train your bladder to be better for you. Once again, pessary, so improving that pelvic organ prolapse. Medication for overactive bladder can also be very helpful. That said, medications are considered second-line treatment. Pelvic floor physio is considered first-line treatment. And then once again, surgery. Okay. This is a big one I like to talk about because a lot of people don't talk about this, and it is shown that people wait 8 years after symptoms of sexual dysfunction to seek medical attention. Sexual dysfunction with menopause affects, I can't remember what the stat is, and I didn't write it down, but it's about 75-ish% of all women that go through menopause. So pretty much everyone that lives to that age will experience some level of sexual dysfunction. We talked about that clitoris shrinking, so it's harder to stimulate the clitoris. Most women orgasm through clitoris stimulation, so you're less likely to orgasm that way. Lower libido. Now, lower libido is very multifactorial. You can't say that's just related to the pelvic floor, but less and hormones, stress, anxiety, depression are major factors, as well as just life changes. And then that decreased blood flow to the vagina that we talked about, making that vagina thinner, less moisture to it. Sexual pain is a factor with sexual dysfunction. So vaginal dryness is the number one complaint with postmenopausal women, is that they're getting that dry vaginal tissue. Because the labia and the vaginal tissue are both getting thinner, and the skin on them is thinner, they're more irritable to friction, so rubbing, as well as to chemicals. What is really important here is that the vagina, the labia do not need cleaning. They are self-cleaning. They only need water to clean them. Anything else can irritate the skin because of chemicals, parabens, other things that we know will irritate the skin, but also dry out that tissue even more, making it more likely to have irritation. You also have a shorter vaginal canal we talked about. So you're more likely to be hit in the cervix or on hypertonic pelvic floor muscles with insertional sexual activities. So if something is being inserted for sexual purposes, and you've got a shorter amount of space, then if your muscles are really tight, just like they are in your neck or anywhere, you are going to get pain and discomfort. So I'm going to just listen to my little sharing this way here. No, I don't. Stop sharing. Sorry. So essentially, most people get tight and sore in here. Over-tight muscles are like these guys here. If you have over-tight pelvic floor muscles and something is going like this to them repeatedly, that's not comfortable. No one wants to do that. You're not going to have sexual activity that involves. So we need to assess for, are you getting pain because those muscles are over-tight and they're sore? The one thing to note, though, is that people that are in a heterosexual relationship, penises shrink at about the same rate that your vaginal canal shrinks as well. So if you are in a lifetime partnership, or even, a new partnership with someone roughly the same age as you, you're going to match up pretty decently that way, at least. So that there. Treatments for sexual pain. So a big one for treatment for sexual pain is understanding what pain is. And the big thing is pain is not from the nerves telling us that injury has happened. Pain is how I'll just actually read the whole definition. An unpleasant sensory and emotional experience associated with or resembling that is associated with actual or potential tissue damage. And it can't exist without personal experience and a biopsychosocial experience. So what society has given you and what you yourself have given you. It is not just your nerves telling your brain that you have pain. It's the whole process together. So to treat sexual pain, we look at treating the whole central nervous system. So those relaxation evoking exercises are shown to downregulate overly tight muscles and bring down feelings of pain and discomfort, as well as increase libido. Dilation therapy. So if the tissue is getting tighter or sore and insertion is becoming a problem, there are dilation where you use different types of dilators, or they're essentially like dildos that you'd go in and start to train to stretch that tissue very gently. Sexual activity positioning. So if you're getting pain in certain positions, based on what's going on with your personal anatomy, you might do better having sex in certain positions than in other positions. And so talking with pelvic floor physio about what those positions might be for you and your sexual partner can be very helpful. You can also treat the hypertonic or overly tight pelvic floor structures with myofascial techniques, so essentially internal vaginal massage, or with stretching of those tissues. And then the other source is topical treatments. So we're going to go into topical treatments here, and then that is more or less our last topic. Sorry, Jeanette, I'm running. I know. I told you I was going to run long. Okay.
Keep going. It's so interesting.
Okay. Okay. So vaginal moisturizer. They make moisturizer for your vagina. Nesters, Whistler, Cells, the three main types that are sold in Canada: Gynotrof, Repagyne, Replens. Hyaluronic acid, which is in Gynotrof and Repagyne, have similar improvements on research to low-dose estrogen therapy when used as the placebo. It's pretty much coming up, they're the same. So we know that these do work, and before going to a hormonal treatment, going to a vaginal moisturizer can be good. Unfortunately, these are rarely covered by extended medical plans, and topical estrogen often is. When we look at the ingredients, Gynotrof itself has the closest to normal vaginal pH, particularly normal postmenopausal vaginal pH. It also has no parabens and less other chemicals that are considered to be irritating. So my usual one is to try that first and then try the others if it's not helping, if you're not wanting to go to another one. Lubricant. A lot of people aren't used to using lubricants, but they can really help. There's a couple different types of lubricants. The main types that you see most places are water-based. So your KY jelly and your Astroglide. KY jelly, Astroglide, full of gross things that are pretty much all considered to be vaginal irritants. They're not an awesome choice. They are the cheapest choice and the most readily found choices, however. Water-based lubricants are slipperier. However, they can get sticky or tacky sooner. They're the most likely to also be irritating if someone has pH or osmolarity, so absorption issues in their vagina. Brands of water-based lubricants are Good Clean Love, Yes, and Slippery Stuff. And I've picked these ones over others because these ones are at a pH neutral level as well as an osmolarity neutral level for a vagina. Silicone lubricants, much harder to find, but I know where to find them if you need. They provide more longevity, so they are typically preferred by women. They are also typically hypoallergenic, so most people are unlikely to have an allergic reaction to any of the chemicals in a silicone lubricant. They are not compatible with some silicone sex toys, and they may stain sheets, so that is not a great factor with them. Sliquid Silver and Uber Lube both have a neutral pH and osmolarity neutral to the vagina as well. Some women for help can use both. So silicone on the vulva and vagina, water-based on the partner or sex toy for getting that slip as well as that longevity. And then the last one, actually, no, I thought I put on there was topical estrogens. So topical estrogens are shown to be safe and effective even with other hormonal treatments because they're not readily absorbed into the bloodstream. So they are actually endorsed for use for vaginal dryness during chemo treatments and other treatments for most types of ovarian and breast cancers. A lot of GPs are wary of that. And if your GP is wary of that, I'm happy to find the information on the American Cancer Society's pages that state why. And it's because of what type of estrogen is used in those topical estrogen creams. They're not all created equal. So sometimes it's trying one topical estrogen to plump up that tissue. And if that doesn't work, try a different brand, get your doctor to prescribe a different brand of topical estrogen. Okay. All right, so putting this all together, I kind of want to put this all together here, and not maybe so much for the sexual health and the vaginal changes, but we saw a few things kind of repeated over and over again during my talk here. Okay, so exercise for menopausal health helps with prevent loss of muscle mass, maintain aerobic capacity, decrease your risk of cardiovascular disease, decrease your risk of falls, decrease bone density loss, decrease your risk of dementia, improve your quality of sleep, increase your libido, and decrease your risk of symptoms of depression, anxiety, and stress. The research is high, it is strong, it is consistent that exercise helps all of these things. There is no good quality evidence that it helps hot flashes or night sweats though, sorry. This is one of my favorite videos I've ever shown on any course ever. So if you'd like a link to it, I can send it to you. Otherwise, it's called 23.5 Hours with Dr. Mike Evans. It is a video that, I just pull it up here a bit. So you kind of-
This is the checkers game where grandson and
3, 2,
granddad will bond.
1, skip ad. So you can see what it looks like. It's this guy drawing this stuff.
Sorry, Dana, we can't actually see it.
Oh, you can't? Oh,
no, we can hear it though.
Okay. Well, it sounds like that guy talking and he's sketching black Sharpie on a whiteboard. And it tells you about this magical cure, this magical treatment that has these great high quality studies showing for it. What is it? It is 30 minutes of walking a day. All risk preventions that I just shown you exist from exercise that can be gained with daily walking. It does not need to be an Ironman. It does not need to be ski touring for 9 hours. It does not need to be biking Lord of the Squirrels. Walking 30 minutes a day minimum will give you the health benefits that I just talked about. And those benefits and that research shows huge increases of 50 to 75% improvements for almost all those ones I talked about. My case for moderate level of activity is more tolerated for more people. You're less sweaty, so more people are likely to do it on their before work or on their lunch break or before dinners. It can evoke that relaxation response, so it can be calming versus ramping up those pro-inflammatory cytokines that some exercise might be doing. It can be more social, so you can talk while participating in them, which is shown to be helpful for stress, anxiety, and depression. It also carries less risk of injury. So when you're not getting out there for exercise because you just don't have the energy to go out and put on gear and get it out of the shed and all of that, just remember you can walk for 30 minutes. And then the slide I realized is in the wrong spot. 30 minutes a day means 30 minutes total a day, not 30 minutes at once. It can be cumulative. So if all you can do is 3 10-minute walks in one day, you are still getting those health benefits. It is still important to do it, and you will maintain a better quality of life by doing it. So here is an exercise plan based on all those things I said that you're at risk of happening. Strength training 2 to 3 days a week for global muscles, for balance, for function. So those exercises would be squats, lunges, bridges, overhead press, a hammer or bicep curl, calf raises, sidestepping exercises, step ups, and grip strength. Essentially, those exercises right there will give you everything you need to maintain good muscular strength throughout your entire body and prevent those muscle injuries that we see in menopausal and postmenopausal women. General strength is done at 8 to 12 reps per set, 3 sets. So if we're looking at general strength, those are how many. You want to be doing it at a weight that when you're starting at 8 reps, you can only do 8 reps of 3 sets of that exercise in good technique. Once you get to 12 reps, you're going to start increasing your weight to the next set. And then once you can do that easily to 12 reps, then you're going to increase the weight again. Balanced exercises. So we know balanced exercise are very important for risk of falls, maintaining quality of life, and staying living in your own home, and for just being able to do our sports for lower risk of sports injury. So balanced exercise is 3 to 7 days per week. It's a big, wide variable range there. So, most days if you can. So single leg balancing exercises, tandem stance, heel raises, clock steps I'm going to do. I'm just going to show actually these ones here. So for balance exercise, so those would be anything like single leg balancing for 30 seconds, tandem stances, the walking on the drunk line. Can you maintain that balance in that position there? Heel raises, start with doubles, progress up to single leg heel raises. Clocks would be even just stepping, but progressing into any kind of lunge. So lunges itself are a balance exercise. What I'm doing right now is a balance exercise. See how it looks a lot like dancing? It's like my good promo for going to do some dancing. Okay, let's screen share that again. Oh. Okay. That cardiovascular exercise. So getting that 150 minutes of minimum of moderate or 75 minutes of vigorous exercise per week. Walking is all you need to do to see the health benefits. Weight loss, you need to do more. More is sometimes better. 150 is the minimum. Evoking that relaxation response daily. Bring those pro-inflammatory cytokines down through meditation, Yin Yoga. Not all yoga is created equal for evoking the relaxation response. Power yoga does not. Ashtanga does not. Yin, good research that it does. Walking or breathing exercises. And then making sure that those exercises you're doing above there are incorporating load for bone health into any of those. So those lunges, getting your 30 minutes by playing pickleball or tennis or hiking, those are incorporating some load daily to prevent that osteoporosis. All right, who should you see when you have different symptoms of menopause? Counseling, we talked about that. Counseling to help with depression, anxiety, stress, sleep disturbances, low libido, coping with major life change. Menopause is a major life change. It's rated up there the same as, it's not the same, there's like a hierarchy, but it's in the major ones, just like having a child, getting married, losing a partner, losing a parent. So it's major life change. So it's a reason on its own to seek counseling. Marital, partner, or family dynamic changing, and that changes as people retire, change jobs, change how much they work, are empty nested, lose parents. Your family dynamics and might change. So that's another time to see a counselor. Your general practitioner. So for some people, a general practitioner is their naturopath as well. We're going to talk about naturopaths next. So yearly assessments for your general health, for cardiovascular disease, diabetes, dementias, for your blood pressure, heart rate, and cholesterol. Should be seeing people for that yearly. To be assessed for bone density and risk of bone density, and then being referred for bone density exams. Having your pap and breast exam. Being screened for depression. Hopefully your GPs are screening you for depression as you age as well. Assessment and testing for other conditions that might be mimicking menopause. So we talked about those thyroid issues or dementias. Referral to a gynecologist if you're having some pelvic floor or sexual dysfunction, or any other specialist for that matter, because of other injuries that might be going on, or heart disease or diabetes. And then also refer to your general practitioner for medications such as topical estrogens, hormone therapies when other things aren't helping, learning about the risks of them and learning about them from your doctor. Medications, the medications do exist for hot flashes and night sweats. They're usually prescribed after something else isn't happening, or other medications like gabapentin or other sleep medications to help with that. Naturopath, see your naturopath for looking at hormone regulation for hot flashes, night sweats, irregular periods if you're earlier in menopause, mood disruption, and supplementation. Supplementation has various levels of quality of research on it. So everyone's going to be comfortable with what their personal comfort levels are. Also seeing a naturopath for nutrition, for osteoporosis or cardiovascular disease. You can also use your naturopath as your regular GP. They are pay for service though. And then the last reason why I'm in this field, your women's health physiotherapist, why you would go see a women's health physiotherapist, increasing your general or specific strength. So normal physio stuff, getting better muscular strength, pelvic floor strength, pelvic organ prolapse, incontinence, so that leaking, bowel movement concerns. Are you constipated? Do you have IBS? And yet, you've been dealing already with diet and that's not making changes. And you've had colonoscopies and everything. And there's nothing coming up as to why you have that IBS. It could be how you're moving your bowels. That could be a factor. Sexual pain, discomfort, dysfunction, low back pain or pelvic pain, osteoporosis health. So what should you do if you have osteoporosis to maintain or build? And then post-surgical or post-treatment for hysterectomy, partial hysterectomy, pelvic organ prolapse surgeries, urethral surgeries, bladder repairs, breast cancer treatment, gynecological cancers, treatments or surgeries, or colectomy. So there's lots of different reasons why you would see a pelvic floor physio. I am not the only pelvic floor physio in the corridor, and I'm happy to refer people to anyone else. I personally only work with, as I said, a female population or a trans or non-binary population. For male population, I do have another physio that I tend to refer people for in Squamish. So if you have questions about pelvic floor health for someone that has a penis or a prostate or testicular issues, I'm happy to refer them to there. So that's kind of everything in a giant nutshell.
Thank you so much, Dana. And I think if the person you're referring to is the person you sent me the contact for a equivalent talk.
Yeah.
Perfect. Yes. So everybody stay tuned. We will be doing sort of a men's health equivalent of this talk coming up. Wonderful. Yes, I'll share the information. Folks, I know some of you have to sign off. We're going to continue recording, and if anybody wants to stick around and ask questions, please feel free to do so. We're going to record the questions as well, and I'm going to send out the video to everybody. So even if you have to sign off now and, I don't know, put kids to bed or go to bed yourself or have dinner or whatever, we understand. But I have a couple of questions that have rolled in through the chat, and if anybody else wants to send me questions, we do still have a few minutes to do that. Is that cool, Dana?
Yeah, I love questions.
Amazing. Well, the first one that I got in the chat was, how can we lower our might not read this correctly, pro-inflammatory cytokines?
Yes. Okay. So you can do that through diet and nutrition. However, most of the research for lowering your pro-inflammatory cytokines is to reduce your level of stress and anxiety. So bringing those stress-reducing activities daily is very important. So if someone is firing, so if I get someone that's coming in and they're telling me that they have high stress levels, stuff like that, I actually make them do a questionnaire to flag them if I think that that's going to be a risk factor to them. And if it is, then I refer them to other practitioners as well. But seeing someone, so generally seeing a counselor or someone that can come up with a game plan of something that you like, based on how people do on these questionnaires, is very personal. Some people are going to do better with meditation. If people have a lot of certain types of anxiety, like where they magnify. So you're like, oh, well, if this happens and this will happen and that will happen. Those people don't tend to do well with meditation, will tend to do better with gentle movement-based relaxing exercises. So I put people through a battery of different questionnaires to figure out what way an exercise might be better for relaxation evoking exercise or activity such as mindfulness or yoga. Otherwise, seeing a naturopath to discuss ways, maybe through supplementation or through diet changes and lifestyle changes, that way is another way to go about changing those levels.
Thank you. Another question that's rolled in, which I think is another great one, is how do we reduce visceral fat? Because it sounds like it is kind of different than
Yeah,
other?
so visceral fat is harder to target. and harder to reduce. And essentially, reduction in visceral fat does come down to dietary changes. So that is one of the bigger ones. So working on dietary changes. And so usually changes into sugar consumption. And that's also then where seeing a natural path, if you have higher visceral fat, would be good. But that 150 minutes a week of moderate exercise is shown to decrease visceral fat levels if someone is at a healthy caloric intake. So if we're at a too high of a caloric intake, we're not going to reduce it. But at 150 minutes, if you have a good calorie intake, you should be able to reduce visceral fat as well. And then, it's also looking at the dietary factors.
So it might be worth speaking to somebody about a plan of attack, so to speak.
A plan of attack. If you are already doing those exercise minimums or a bit more, and you're not seeing changes.
Wonderful. Another question that I had submitted was, so you spoke about how post-menopause, and I might not remember this correctly, some things tighten in terms of muscles, some things loosen, some things tighten. Anything to counteract the stiffness, extra stiffness you might experience?
Yeah, so you're going to have it, but maintaining exercise and mobility. So having a good mobility plan. So what we know about stiffness is essentially research is now showing that prolonged stretches don't tend to help prevent tightness or stop tightness. They do it temporarily, but mobility exercises maintain and better lengthening. So dynamic stretching, dynamic movement exercises, that's where the yogas would come in. Just general fitness and a general kind of top to bottom mobility exercise would help with that. And so, that would be, for mobility, seeing a physio or a personal trainer to work on some mobility exercises for maintenance.
Thank you. Another interesting one, and this goes way back to the beginning of your talk, when you were talking about how to tell when you're becoming perimenopausal or menopausal. What about people who are taking hormonal birth control? How does that interact with the natural process?
So that one, there's a lot of big changes with that one, particularly when people are on IUDs. It's not easy to show. And there's actually talk now coming up in a lot of the gynecological groups that wanting to maybe remove IUDs sooner because that tissue is shrinking and tightening. And if someone has gone through menopause while an IUD is still in place, they can sometimes be harder to remove. That said, having IUD in place for a lot of women can help regulate some of those menopausal symptoms. So there is, there is that. And that's when you are going to be talking to your GP about, when are you going to think about continuing birth control or not continuing birth controls based on other symptoms you're having. So if you are having those symptoms of hot flashes, night sweats, irritability, fatigue, sleep difficulties, higher rates of stress and anxiety, things that could be markers that you are going through menopause, then see your GP, because it'll be a lot harder to tell if you're not regularly having your periods because of birth control.
I'm sure you could unpack that further and further and further.
Oh, there's so much information around birth control, and even with athletes, when to take birth control, when not to take birth control during training sessions and stuff too. It is that is a whole different level in physio.
Yeah.
That's something different.
That's another talk.
Yeah.
That is all the questions that I've received. I don't know if there are any other last minute questions out there. Folks, you're welcome to connect with Dana yourselves after this talk. She's available. She's here in town, and she's a wonderful resource. So if I don't see any other questions rolling in. I'll just remind you one more time that I am going to send out the recording of this session, and you're welcome to share it with people who weren't able to make it tonight. So you'll receive that tomorrow morning. I'll send it to everybody. I also wanted to do a shameless plug because Dana has mentioned that meditation and mindfulness can relieve some of these symptoms.
Yeah.
We actually offer a monthly meditation class at the library. Whistler Meditates meets virtually on the second Wednesday of every month. If you're interested in that program, you can email me. When I email you folks the video, you can respond to me and say, hey, put me on the list for Whistler Meditates. We're throwing in some in-person stuff as well, but we're sticking with virtual for our monthly meeting. And I think that's it from me. Anything else from you, Dana? Any final take-home message?
Exercise is good. And often so much of that talk did come down to, genetics and your 150 plus minutes a week, that if it's working for you, do it. If you're trying something you don't think it's working for you, as far as like exercise or treatments and stuff, talk to someone else about it, and see if you can get something different that will work for you. Just talk to someone about it, because we just know that so many people, all women are going to go through menopause. So many women don't ask for help or don't get help as soon as they start having symptoms that are bothering them. And the sooner you talk to someone, the sooner you might be able to resolve some of those symptoms. I am going to give Jeanette a modified version of my PowerPoint notes too, particularly because I want you to have some of that information on exercise. And so she can email that out with the video as well. So you guys have that, and also some of the other just general information on there. I am happy to take any kind of question. So if you Google my name, I have a personal website. It's about to be relaunched, so it's kind of not great right now, so deal with it. Or through my work at Back in Action Physio. You can also get my contact from Jeanette. I'm happy to answer any questions that you might have. Just give me a few days. If it is too specific, I might not be able to give an answer, and that's when I would say come in and see me or go in and see a different practitioner. I can't do, unfortunately, everything under my licensing for free or over email. But I'm happy to answer the questions as I can.
Thank you so much, Dana. All right, I think we are going to call it a night there. Thanks again for everybody for being here. Thank you to Dana. Stay tuned for that men's health talk that we're going to offer. You can drag your spouses, or I don't know, send your sons, send your dads, so that they can all benefit from it. And thank you to everybody for joining us tonight, and we are going to call it a night there. So thanks, everybody.